Hello and welcome to another episode of the Life After Cardiac Arrest podcast with me, your host, Paul Swindell. Today I'm joined by Professor and Consultant in Neurology at Lund University, Tobias Cronberg, who has a special interest in cardiac-induced brain injuries. Welcome to the show, Tobias, and it's great to talk to you.
Thank you, Paul. Very nice to be here.
And just to say that you're in Sweden at the moment, aren't you? And how's life there?
Well, the sun is blue and the sky is up, but of course we are suffering from the pandemic as everybody else. So it's an extraordinary situation, but it hasn't hit the southern part of Sweden very much yet. So we are still rather much business as usual.
Yeah, so you were just saying before we started recording, your life seems not quite normal, but it's not as drastically hit as it is in the UK.
That's right.
And I just wonder if you could briefly introduce yourself and tell me a little bit about your interest in neurology and in particular cardiac arrest-induced brain injury. How did you come into that?
Well, I try to make a long story short. It started actually during my early years in Lund from the middle of the 1990s when I was working in a laboratory doing my PhD in experimental brain research. And we worked a lot with stroke models and with models of cardiac arrest and basic mechanisms of cell injury after cardiac arrest and stroke, which is two rather similar diseases in the sense that the blood gets a loss of blood flow for a period, and then we have a reperfusion of the brain, and then we have a damage. And the mechanisms are quite similar, actually. So it started then, and when I had done my dissertation, I was working full-time clinics, and I got interested in the cardiac arrest population. I started a collaboration with Hans Friberg, who was intensive care physician at that time and who is a professor there now. And we started with hypothermia treatment early in 2003, when the two important studies were published showing that cooling patients after cardiac arrest had a protective effect. And we were strong believers of hypothermia, and we wanted to study outcome in those patients, long-term outcome, and also to look at different methods to try to diagnose brain injury and to try to decide the prognosis for the patients in the ICU when the patients were still unconscious. And we started working with different methods, mainly biomarkers in the blood, clinical neurological examination, and electrophysiology, where we could work with continuous EEG, for example, as a method to look at the brain activity after cardiac arrest. And we started publishing our results about this, and gradually we got more and more international collaboration. Niklas Nilsson, who is intensive care physician in Helsingborg, became part of the team, and he was very important for us building up a big network of international sites in the hypothermia register, which was the foundation for the first Ttn trial after that, which we did in 2010 until 2013, studying the effects of temperature management in patients.
When was it sort of first realised that hypothermia could be sort of therapeutic and be a useful tool in the medical toolkit, as it were? I mean, I guess people have known for quite a long time. I mean, when I used to play sports as a youngster, and if I got a strain on my leg, you get an ice pack put on your knee or the muscle or whatever, and that would help alleviate any inflammation there, and you get back to playing the sport quicker. But when was it sort of the light bulb moment, if you like, that, hey, we can use this in a bigger way for something like the brain?
Well, that has been known for the brain. It has been known for many years. that it's possible to cool a patient, for example, to be able to do thoracic surgery in the main aortic vessel. To be able to stop the blood flow to the brain, you have to cool the patient very much, all the way down to 19 degrees. At that level, it's almost like putting the brain into the refrigerator, and all biological processes slow down very much. Very similar to what happens in your knee, actually. You slow down all the biological processes, all the damaging, degrading processes are being slowed down. And for a patient operated and thoracic surgery, you could keep operating for approximately 1 hour at the temperature of 19 degrees. And during that period, you have basically no activity in the brain. If you look at the cortical activity with an EEG, it's completely silent. And then you could rewarm the patient, and they will be functioning more or less normally after that. Maybe some minor problems, but most patients could return to normal life. And comparing that with a cardiac arrest, it would be completely impossible to have a human who is without any circulation and normal body temperature for 1 hour. After that time, you're certainly dead. There's no chance to revive that person if the body temperature is normal. So it has been very obvious, and it has been known for a long, long time. But there were early research on this. I'm not sure about the exact years, but there were pioneering research done in the US, in Pittsburgh, at the Safar Institute. And then it was more or less abandoned until the 1970s. When there was a major new focus on hypothermia in experimental settings, and a lot of experimental done in animals with mild hypothermia, not down to 19 degrees, but only to 32, 33, or maybe 34 degrees. And it was shown that this was effective in different models, experimental models of cardiac arrest and stroke for that. So when I got to the laboratory and started my research in 1995, it was very well known. And in that laboratory here in Lund, a lot of the pioneering work had also been done on hypothermia in experimental animals. And for me, it was very clear. Also, I worked with the whole animal models, and I also worked with cell cultures. And when we did this ischemia in the cell cultures and we just lowered the temperature, the cells didn't get damaged. So it was sort of a concept that was very much, for all the researchers, very, very clear concept that hypothermia works. And then we had these 2 trials in 2013 showing in a clinical setting that it worked also in patients. And that led to a major implementation over the whole world of hypothermia treatment. But unfortunately, those 2 trials were not very good trials. They were small trials. One Australian trial from Bernard and his collaborators, which with only less than 100 patients, I think it was 77 patients, and then a European trial, which was stopped early because they didn't have enough funding, and they had, I think, 273 patients, which is not very much in these circumstances. So for us, later it became evident that we need more information in patients to know whether it is effective or not. We need to do large clinical trials to study temperature management, hypothermia treatment in patients.
Could I just take you back to one of the things you were saying when you were doing your study in your PhD? You were saying you were looking at animals. Do animals, though, they have a lot of them have a natural ability to hibernate anyway, don't they? So how does that come into the picture? And do humans have anything like that?
No, humans don't have that ability to hibernate. And the animals used in the experiments for hypothermia don't have that ability. So a rat, which is the most common laboratory experimental animal, it can't hibernate. And pigs has also been used, but not very much. But animals and rats and mice, they don't hibernate.
And also, as I mentioned to you just before we came on the air, there was a famous case at the end of the 90s which featured a Swedish doctor, Anna Baggenholm, who I believe experienced a case of hypothermia for a couple of hours, I believe it was, because she was skiing in Norway and fell into a river. Do you know much about that?
Yes, I remember. I know. I've seen a program on television about her. This is a very, very interesting case, and it's sort of a proof of principle case with Anna Baggenholm, because what happened was that she was skiing and down a slope, and she went out on the ice at the end of the slope and was sliding out on quite thin ice actually, and got trapped with her head into the water. And was and drowned on the ice with her head being put into the water, and then she had a cardiac arrest, if I've understood it correctly. So it is not an unusual situation with cardiac arrest in the circumstance of drowning, of course. But what was very special with Anna Baggenholm and ideal for her was that her body and particularly her head was cooled before she had the cardiac arrest. And we also know that from experimental settings that the most protective effect of cooling is if you cool the brain of the animal or of the human in this case before the heart stops. Because then all the damaging processes will be much slower. And for her, they couldn't rescue her because of the thin ice, so her friends couldn't rescue her, and they eventually got a helicopter, and somehow they rescued her, and she was transported and put on artificial circulation in the helicopter, and slowly rewarmed, and very, very slowly her heart started beating again. And it was so remarkable because she had at least, I'm not sure how long, but at least 1 hour of circulatory arrest, and that's very similar to these thoracic surgery patients, and that explains why her brain didn't get damaged or more damaged by the cardiac arrest.
I understand that she was like over 2 hours in arrest, and her body temperature went down to 13.7 degrees, which apparently was the lowest ever recorded, and it's pretty amazing. But I don't know if you saw the news last year, towards the end of last year, there was a report of a British lady who had a similar case who suffered hypothermia in the mountains of Spain. And she arrested for 6 hours, I think it was. But they managed to bring her back. And they always say they made a full recovery. But of course, we'll never really know whether she has made a full recovery.
No, but I think there's a very strong and important message here, and that is if you are cooled before you have the arrest, then you have a very favorable situation. And that's also very well known to doctors that you cannot decide that the person is dead before the person has been rewarmed, because there's always the chance that the cooling or the chill has had a protective effect and that the patient will survive.
There's a saying, isn't there? You're not dead until you're warm and dead.
Exactly. And it's also interesting, we did a meta-analysis of the experimental data on hypothermia after cardiac arrest, all the animal research we put together and looked at the evidence in favor of hypothermia. And it showed that the strongest evidence is for pre-arrest cooling or intra-arrest cooling of small animals. And we have actually all too few data on large animals with post-cardiac arrest cooling, which is what we do with the humans when we are cooling after arrival to hospital.
Obviously, we don't know for my cohort, for people like myself, we don't know the majority of them are going to go into an arrest. So we can't really put us into a cooling situation firsthand unless you're there by chance. But do you think it would, I don't know if the technologies are there, but in first aid situations with paramedics and things like that, would they have cooling apparatus with them? Would that be a practical scenario for them to adopt in the future if they know that, as well as getting a defib and doing CPR, that we get a cooling pack, whatever that looks like? I don't know. But is that something that you could see perhaps coming in the future?
Well, we can't exclude it, but there have been studies trying that approach because it's so obvious from experimental studies that it would be a great advantage. So there has been a big study looking at pre-hospital cooling with intravenous cold fluids. But that did not show any benefit. There's some signal towards harm because cold fluids will give you a load on the heart, so there's a risk of cardiogenic shock. The patients will go into shock because of the fluids. So that was not a good approach. And then there was a study which was centered from Stockholm in Sweden with nasal cooling, where they tried to cool through the nose of the patients with a special technique with evaporation. And that didn't show any effect. However, a small signal towards possible effect. At least it can't be excluded that it may have some effect, but it was not a significant effect anyway. And it may tell us that it's the main thing if a person have a cardiac arrest is to get the heart restarted. And if we start doing other things, maybe we won't be as successful restarting the heart.
That's true.
So there are problems with any approach. And if we compare a human to a mice or a rat, well, it's much more difficult to cool a human. You can't just put a few ice packs. It won't do much difference. To lower the body temperature of such a big animal as a human, it takes a lot of time and a lot of effort and a lot of cooling power.
Okay, so can we go back to sort of the turn of the century? It sounds a funny sort of phrase. So back at the early 2000s, you said you noticed that it was obvious that cooling worked for you. So you started doing that in your hospital then, presumably?
Yeah, that's true.
What did you start seeing?
Well, it was a great enthusiasm, and the big thing I think at that time was a shift in favor of the cardiac arrest patients. They became a very interesting patient group in the ICU because it suddenly cardiac arrest went from being a condition where we could do nothing to become a condition where we could do a lot because we could do cooling with the cooling machines, fancy new apparatus. I think that was very good for the cardiac arrest patients, and it was shown in many registers that survival went up after the introduction of cooling. I think that's important to remember as well, that probably many things improved for the cardiac arrest patients because before that time, it wasn't obvious that a cardiac arrest patient would go to the ICU. They may even go to a regular ward without any artificial ventilation. And now, because they needed to be sedated and artificially ventilated during the cooling process, they probably got very good intensive care in the package, so to say. Also, we started with more advanced methods to diagnose brain injury, to be able to do a more advanced prognostication to decide which patients would have a good outcome eventually and which patients had such severe brain injury that it wouldn't be beneficial to continue treatment. And that was also probably very good for the patient. It made the care more safe and the decisions around life-sustaining therapy more safe, I think.
Were these patients in hospital cardiac arrest victims, or were they out of hospital, or were they both?
Both. We didn't make any difference whether it was in hospital or out of hospital. For in-hospital cardiac arrest patients, they often have more significant comorbidities because they're in the hospital for a reason. And that may be a reason not to to give full intensive care, for example, for a patient with a advanced cancer of some kind. It may not be of benefit for the patient to have that care. But those decisions have to come later. When a patient have a cardiac arrest, it's full action and full intensive care from the beginning. And then you can sometimes have to back off.
What was the scenario in Sweden at that time? Because the sort of general consensus from the UK is that the Scandinavian countries are ahead of us in the curve, as it were, regarding having AEDs in the community and encouraging people to do CPR and having the equipment and the processes in the hospital once you get there. Then
I wouldn't say. I think it is at that the curve is lifting around that time, around 2000, or even later. So I think you could see the real surge in survival rates in Sweden comes after the introduction of hypothermia. But at the same period, there is a lot of training in CPR in the community, and this public movement of lay people, CPR, is around that time. And we have seen very clearly in the Swedish cardiac arrest register how survival and the use of bystander CPR are parallel curves.
So you've been doing therapeutic treatments for a while then, and then had that been spreading around to other hospitals and to other parts of the world? And then what was the motivation for coming up with the TTM trial, the initial one?
Yeah, so the introduction or the implementation of therapeutic hypothermia was a global movement, and a lot of believers who had been doing experimental research perhaps, or were just doing clinical research, were implementing this treatment all over the world in a parallel process. So it wasn't something that spread from Lund to other places, certainly not, but it spread from many places. And there's still very much of a movement and a great interest in hypothermia all over the world. But the TTM, so we were also part of the believers, because we had so much evidence from the experimental research, as we thought at least. And then Niklas Nielsen, he did a meta-analysis of the clinical evidence for therapeutic hypothermia, together with the clinical trials unit in Copenhagen. You know, Copenhagen is very close to Lund. It's just over the sound here, and we have a lot of collaborations. And Niklas worked with very good statisticians and clinical trialists in Copenhagen, and they could show that the evidence for therapeutic hypothermia in humans were insufficient. And that it could be a benefit, or it could be no benefit, or it could even be harm. We couldn't tell from the studies that were performed. And I think that changed something fundamentally for us in the group. And we decided to do a large international trial, and we started to form the group around the TTM, the first TTN trial. When we were discussing the TTM trial, we first thought that we would just redo the previous trials and just test whether cooling is better than no cooling. But since the guidelines at that time, they recommended cooling for these patients, many people thought it would be unethical to randomize patients to no cooling, since a lot of people all over the world thought that it was shown that cooling was working, and the guidelines stated that it was shown, or there was evidence, strong evidence in favor of hypothermia. So therefore, the first TTM trial was a bit of a compromise, where we decided to compare two different targeted temperatures, 33 degrees and 36 degrees temperature, where 36 was quite similar to no treatment, or as far as we could go in that direction. And then we did this very large trial with 950 patients, so it's much more than the other trials together. And we saw absolutely no difference between 33 and 36 degrees. And I think that was very, very surprising for many people in the field. Because from the experimental research, we should certainly have a very big difference between 33 and 36, but we didn't. And we looked at a lot of different outcomes for the patients, of course, survival, of course, neurological function at 6 months after the cardiac arrest. And we looked at cognitive function in detail. We looked at biomarkers of brain injury in the blood, and we saw no differences between the groups. So that led to a change in the recommendations from the international organizations that 33 or 36 degrees is just as good.
You still felt that cooling was better than no cooling?
Well, I felt that we needed to take it all the way. I didn't feel that, personally, I didn't feel very strongly that cooling was better than no cooling. I felt that there may be an effect still, but I'm not sure. And I'm still not sure because we are still doing the TTM2 trial. I think it's equally possible that there is no effect of cooling as that there is an effect.
Oh, interesting. So what is it the people who say that cooling works, what is it they think is actually happening with the brain and with the body when you actually cool someone? What processes are we changing?
Well, what we are certainly doing a lot of things in the brain when we cool a patient. That's no doubt about it. I mean, we slow down all the biological processes. It's just the same as when you take your package of milk and put it in the refrigerator. You protect the milk from breakdown, and you protect the brain from breakdown and damage due to a lot of different processes. That has been shown in the experimental animals, and we have proof of principles with this physician who went into the cold water, as you referred to, and we have from patients being cooled for thoracic surgery. We know that it's a very potent treatment, but we don't know if when we do it in a delayed fashion, as we do with the patients today, if that is effective. And that's my major doubt. I doubt that we do it early enough. I think we would need to be much faster and have some kind of method to very effectively, without any side effect, cool the patient on the scene. I doubt that it is effective to do it as we do it.
So do you think that the damage is already done, as it were?
Exactly. That's what I'm afraid of, at least, that we are not protecting the brain early enough.
And I guess that comes back to what we briefly talked about earlier, getting the paramedics equipment to be able to do that. But then, as you said, that adds another job to be done, as well as trying to restart the heart, which is obviously the most important thing to do. So it's a tricky one, isn't it, really?
Yeah. So this with hypothermia treatment or targeted temperature treatment is something that we will be living with for many years to come, I'm sure. And we will have to work with it and try to refine it to get as much as possible out of the treatment. But I'm not sure that what we are doing today is effective.
Are most hospitals these days, do most cardiac arrest patients, say in developed nations, will they experience the cooling that you've been talking about?
Yes, I would say so. Certainly in the Scandinavian countries, but it varies over Europe and it varies globally as well. I think it's a lot more variations in the US, but there's big variations within Europe as well.
Well, you're currently undertaking TTM2. So how does that differ from your original trial?
Yeah, so in the TTM2, we are taking the question one step further. We are now trying to evaluate whether hypothermia to 33 degrees, as in the TTM1 trial, compared to no cooling unless the patient gets fever. So we in the control group, we will only treat those patients who develop fever, which is a body temperature above 37.8. So if a patient gets 37.8, we will take them down to 37.5 and keep them there with a cooling device for the first 24 hours.
Do people naturally go into a fever after they've had a cardiac arrest?
Yes, many people develop a fever after cardiac arrest, and that's probably part of the global systemic organ damage with the global inflammatory process in the body. So it's common that you develop fever, and the more fever you develop, the worse is your prognosis. So it's related to a worse prognosis to have fever. So that's the reason why there is a recommendation to treat fever, and it's the same in stroke. Actually, there's a recommendation to treat fever because there is an association with a worse outcome. However, whether we are actually doing something good by cooling, we don't know, because it may be that it's just a marker of a more severe damage. So we don't even know that for sure, but we thought that in the TTM2 trial we will take it just one step further and decide whether cooling for patients who do not develop fever, whether that is any good or not.
Yeah, it's interesting. And so how far along are you in this trial?
The TTM2 trial has included 1,900 patients, just as planned. It's the largest cardiac arrest trial ever performed. And we are now performing the follow-up, the 6 months follow-up, and trying to complete it. It has been a problem with the COVID pandemic, of course, because we can't see the patients face to face. We have to do follow-ups with the telephone instead. But we are pressing on with our schedule, and we believe we will be able to publish the results in the end of this year or the beginning of next year.
Okay, that's great. So what are the outcomes you're looking for? Is it just not that they survive, but they survive with particular or better neurological outcome, is it?
Yes, certainly. We are looking at different things, but the primary outcome is survival. And that's because it's a very robust outcome of the cardiac arrest. You can never manipulate survival. Either you survive or not. And you can't get any kind of influence from your own perceptions into that. But the secondary outcomes is quality of life of the survivors and also their neurological function in more detail. And then we have a lot of exploratory outcomes where we are looking at their cognitive function, their physical activity, and how they are participating in community, etc., etc.
Okay. So you say you'll be publishing next year, and then do you get a feel for whether this has been a benefit doing TTM2 as opposed to TTM1?
Yes, I mean, it will have a fundamental impact if we can show that hypothermia is, or cooling to 33 degrees is effective. Then I think a lot more centers will start using this treatment all over the world. There will be a very, very strong signal for working to refine hypothermia treatment as well. But if we don't show any effect, it will be to the other side. People will probably stop doing hypothermia for patients who don't have fever. That will also have a fundamental effect. So I think the world is rather much, the cardiac arrest community is rather much waiting for the results of the TTM2 trial.
Yes, I can understand that. a lot of weight on your shoulders.
Yes, it is.
I'd just like to finish off this conversation about therapeutic management is sort of throw you a left field type question. Do you think we can use this sort of technology to put humans into a sort of pseudo hibernation so that maybe it can be used in other fields like space travel or preserving people so their lifespan is longer?
No, I don't think so.
No?
I don't know, but to slow down your metabolism may be good for you. It may make you live longer. There are some data that starving is a slow grade starving will make you live somewhat longer. Cooling down the body and then reawake a patient. or a person. I don't know. It's sort of a scientific future that I don't want to be part of. At least I think we are so many people on the world anyhow, so we should leave space for those coming after us. But that's more an ethical issue, I guess. Of course, hypothetically cooling down somebody and putting them in a spaceship and having some machine to thaw them when they arrive, it's theoretically you may be right, maybe possible, for long travels extending over 100 years or something like that,
or maybe even, I don't know, over shorter periods, like getting to Mars or coming back from there can be a couple of years, I believe, if you leave it at the wrong time in the orbit.
Yeah. I think you could. Probably you could extrapolate from your package of milk again that putting the milk in a refrigerator will buy you some time, but not a lot of time, a few days before it gets sour. But putting it in the freezer will buy you a lot more time. It's still a limited time, and putting a human in a freezer, I don't think we will be able to thaw them afterwards because there are so much cell damage.
It's not all good news then being in the freezer.
No, I don't think so.
Okay, Tobias, thank you very much. It's been a really interesting conversation about this subject, which is, it's played a part in my recovery, and I'm sure it played a part in many other people's recovery as well. And I'm really glad that you guys are looking at this subject and that you did back at the end of the 90s last century. And it's going to be really interesting to see the results of TTM2 and where that takes us. So good luck with it all. I hope we'll speak again soon.
Thank you, Paul. I just want to say a last word, and that is that even if we would show that therapeutic hypothermia is ineffective in the way we use it today, it wouldn't mean that the treatment has not been beneficial for the patients. I think it has been tremendously beneficial because a lot of things came with the package, a lot more focus on the cardiac arrest patient in the ICU. A lot more artificial ventilation, a focus on that, sedation regimes, EEG, surveillance, etc. We will talk more about that.
Yes, it's very valid points, and thanks for raising them.
Thank you.
Thanks a lot. Bye-bye.
Bye.
This concludes this episode of the Life After Cardiac Arrest podcast, and I'd love to know what you think. And you can do that via Facebook, Twitter, Instagram, or the website southerncardiacarrestuk.org. And you can find us by Googling Southern Cardiac Arrest UK or the Life After Cardiac Arrest podcast. If you have found value in this or other episodes, please help spread the word by leaving a review on your podcast provider such as Apple or wherever is convenient. And don't forget, if you want to know more about Life After Cardiac Arrest, check out our books, Life After Cardiac Arrest, on Amazon. Make sure you click subscribe, and I'll speak to you next time.